Thank you for the invitation, and I'm delighted to be able to speak about the Global Psoriasis Atlas, which has been heavily trailed already, so some of the hard work's been done for me. These are my disclosures, and this is what I'm going to talk about. The WHO report, which led to the Global Psoriasis Atlas, the Global Psoriasis Atlas itself and what it's about, and then some work we've done in Tanzania and in South America, which sort of emphasizes the disparity in availability of therapy and care, the role of the WHO with essential medicines, importance of early diagnosis, as you've already heard, is so crucial in many parts of the world, and then using the Burma Skincare Initiative and Myanmar as an example, how you can task share and move the care of psoriasis out to the community, which is what I was alluding to earlier. You've just heard about this, this monumental decision by the WHO to approve psoriasis as being a serious non-communicable disease. And once the WHO do that, then there's a lot of things can happen. You've got that WHO kudos, which allows you then to move forward with a research agenda. And shortly after that, came out in 2014. In 2016, the WHO published this report. It's only about 60 pages. It's worth reading, and it sort of distills down all the important questions that need to be answered about psoriasis. And one of the top ones, priority areas for research, you can see, need to know more about the epidemiology of psoriasis, the prevalence and the incidence of the disease. What is the disease burden across the world? So we approach that as the key objective, of course, of the Global Psoriasis Atlas. And that was a group came together. It was the IPC, ILDS, and IFPAR working together as the collaborating organizations to found the Global Psoriasis Atlas. But we took advice from epidemiologists, dermatoepidemiologists from around the world, particularly for those who had been involved in working out the epidemiology of eczema. And this was a publication that came out of that as we started to construct the GPA. And we modeled the GPA on the Diabetes Atlas. That was founded about 20 years ago. It's now the go-to resource for information about diabetes, not just the prevalence, but also the burden of the disease, the cost as well. And our vision, don't want to be shrinking violets here, to become the leading epidemiological resource on psoriasis globally. This is the core team based in Manchester, though I'm mainly based in London now. Myself, Professor Darren Ashcroft, who's our research director, I think might have been talking at the IFPAR meeting recently, and Rebecca Swan, who's our program manager. And we have a stand in the exhibition area, I think in the patient village, for you to visit to learn more about the GPA. So the first thing we did was to launch in the first 3 years. It was founded in 2017, when the first 3 years was 2017 to 2020. We launched the Global Psoriasis Atlas on World Psoriasis Day in 2019. That's the website. If you go onto that, it's got a lot of information about the prevalence of psoriasis, incidence of psoriasis in various countries around the world, as you can see here. And the work is due to our fantastic global network of dermatologists. We have regional coordinators, and we have, particularly in South America, it's very well developed. Claudia and Ricardo Remiti from Brazil are the regional coordinators, but they have a very strong team of national coordinators working with them, and we hope to replicate that in other regions. The key study that came out of that first 3 years was this, at that time, the largest systematic review of the epidemiology of psoriasis. And that's where we come with the number, the accurate number, I believe, a number of people around the world who have psoriasis, 60 million. So as you already heard throughout this symposium, it's not just, people take 2% as being the prevalence. Well, that's true in Europe, but it's not true in many countries around the world. So you have to balance it up, and it comes out about 60 million, but a lot of regional variation. And then we've now done studies in a number of different countries. We're starting to gain pace. The most recent one that we've done, which was published in the British Journal of Dermatology just recently, was in Malaysia, where you can see the prevalence is 0.34%, and we were able to show there are differences in prevalence between the Indian population there, Chinese and Malays. So So you can start to break that down. We've just published on the global and generalized pustular psoriasis in that same population. We're now into phase 3, just got the funding for another 3 years, 2023 to 2026. And our key objectives within that, as I'm now going to move into the availability of therapies, epidemiology, always going to be the case, making the diagnosis, understanding the economic impact, and of course recognizing the comorbid burden of psoriasis, and then our field surveys, and I'm going to talk about a couple of those. So in that WHO global report, first it was about the research, the epidemiology, but they asked 3 other questions, or a call to arms, I guess, for governments and policymakers about early diagnosis, access to treatment, and task sharing, which means other non-dermatologists should be also taking on the workload of managing psoriasis and identifying it. And this is where the diagnosis of psoriasis is so important. We think we all know how to make the diagnosis, but many places around the world, because we're talking about a global disease, are not. The diagnosis of psoriasis is missed. Often, as we found working in places such as Tanzania, it's misdiagnosed as tinea corporis, fungal infection, and they're inappropriately treated. They may never get to see a dermatologist, may never get to receive appropriate treatment. So how can you change that? Because if you can get the diagnosis more quickly, you can get more people onto the right treatment. And that's not just true in lower middle income countries. This is, well, you might actually say that United Kingdom nowadays, since Brexit, is now also a lower middle income country in a resource poor setting. But what we've shown here is that general practitioners in the UK also miss the diagnosis, maybe up to about for 5 years. So it's tinea, they say it's itching, dry skin, eczema, and then they realize it's psoriasis. So it's 5 years wasted. The patient's already developing comorbidities. So one way we've tried to address that is what I call an old school way of making the diagnosis, going back to basics. And this is some work that we started with the International Psoriasis Council, an E-Delphi exercise, an iterative process, working with 50 dermatologists from 27 countries from around the world. Well, what is the essential diagnostic criterion for psoriasis, and what are the supportive criteria? And what we came up with was the one essential diagnostic criterion, as you can see here, is the well-circumscribed plaque, with or without silvery white scales. We don't mention the colour. The colour comes later further down, as you've heard from this excellent lecture from Mihira. The colour is not red or erytheme, whatever you want to use, in black and skin of colour. It's often grey, silver, so you've got to be aware of that. So one essential and at least 4. But when you're teaching non-dermatologists about how to make the diagnosis, just the words are not going to help them. They've got to have some pictorial representation of the psoriasis. Now, I haven't gone off track here. I haven't gone on to a separate lecture. This is relevant. If you are a bird watcher, a lot of dermatologists are bird watchers, and you go out into the local botanical gardens here in Singapore, you want to identify the birds, you take with you a field guide. The field guide doesn't have photographs of those birds in it. It has artist illustrations of the birds with the identification features highlighted. So we thought, well, maybe we should try and do this for psoriasis rather than having lots of clinical images. So we asked a medical illustrator working with the Psoriasis Atlas to come up with these clinical images on skin, in skin of colour in different forms of psoriasis. And we trialled that in non-dermatologists, nurses, GPs and pharmacists, and we found it improved their ability quite markedly to make the diagnosis of psoriasis. And we're now trialling that in many countries around the world. So getting the diagnosis right is very important to availability of therapy. Now, before COVID, we did a field survey in Tanzania, and we were hosted by the Regional Dermatology Training Center for Sub-Saharan Africa at Moshi. The key aspects that came out of that, large population in Tanzania, 57 million, only 31 dermatologists, and the diagnosis, as I've mentioned, was mainly made by non-dermatologists, and topical therapies, not very much available, and the only systemic therapy was methotrexate, which could only be used for a matter of about 3 or 4 months, because some of the patients had to travel such a long way for follow-up, it just wasn't going to work out. So that's important to understand the local circumstances. We also then did a survey of skin disease in Maasai people, the first one to be done, which was published in the British Journal of Dermatology. We saw no cases of psoriasis in the Maasai people, which was interesting. But also, we had to go to this disused church. We set up our clinic there. This is the pharmacy that we brought with us. There were dermatologists from the RDTC who actually were ran the pharmacy. And this is the formulary that we used. Very limited number of drugs you can use. So many topical therapies. As it was, we didn't see psoriasis, but it would be appropriate if you're looking for psoriasis in other populations. What about then bigger studies? This is some work done by Matthias Augustin and colleagues working with the World Bank and looking at the availability of systemic therapies, or more importantly, across Europe, dermatologists who are prescribing systemic therapy. And you can see here as you go across, from left to right, that here particularly in the Northern European countries, most dermatologists are prescribing systemic therapies. And then for biologics, again, this is from a few years ago, but it shows what can be done, and there's a sort of gradation which correlates pretty well with the amount of healthcare spend. So the more wealthy the country, the more likely they are to be using biologics, as you see here. Now moving to another part of the world, some great work done by Dr. Tatiana Moll, who's here in the audience, where we worked with Tatiana to do a survey of available therapies for psoriasis in Chile. We were hosted by Claudia, and in Brazil, hosted by Ricardo. And I learned a lot there. We actually then sort of worked on the questionnaire with Tatiana to really understand the access to treatment. And a couple of slides from the paper that's just been published in the British Journal of Dermatology, which is a sort of a good way of, a good exemplar of how to do such a study. And the key findings, again, sort of keying off what they've done in Europe, so access to systemic therapy for psoriasis in Brazil and Chile. And you can see there are differences between the two countries, Chile in the darker blue, Brazil in the lighter blue. You can see that in Chile there's less access to systemic therapy and for biologic therapy. And certainly when I was working there with Claudia, for dermatologists could not prescribe the systemic therapies or biologics, they often had to refer the patient to a rheumatologist, which for a dermatologist is an extremely painful thing to have to do. So, but I don't know if that's improving, but it's not ideal, is it? No.
It isn't.
And then looking at it the other way around, the availability of non-biologic therapies. But when people think about lower middle-income countries and the Global Psoriasis Atlas, they think about tropical medicine, and they think about hot countries in sub-equatorial. The next survey we did, because we couldn't go anywhere for 3 years because of COVID, was into Greenland, working with the University of Copenhagen. And this is the group that went there. Tatiana was in that team as well. We spent time in a very remote place on the eastern seaboard of Greenland, which was only accessible by helicopter in the winter months, even in the early summer months in May. We saw a lot of psoriasis, more than we expected, 17 patients. And if you read the textbooks, they say psoriasis doesn't exist in the Inuit population. And the reason that that they come up with that sort of conclusion is because the diagnosis has been missed. Because it doesn't look like psoriasis. It looks a bit like sort of nummular eczema or a bit of dandruff, a bit of seborrheic dermatitis, and it's been missed. Therefore, these patients are not treated appropriately. Access to treatment was difficult. If they needed biologics or systemics, they had to come from Denmark. And then also working with the WHO, Rod Hay particularly has been working through the essential medicines list with the WHO, now looking to get drugs approved specifically for psoriasis, so topical vitamin D analogues. We hopefully will get methotrexate approved, and we're talking to them about trying to get biologic biosimilars approved as well. And then just to give you an example of how things can change the way that you manage patients, this is a charity that I've had the great privilege to co-found with Dr. Sue Lewin, who's also in the audience, called the Burma Skincare Initiative, which is there to promote excellence in skincare for the very underserved population of Myanmar, Burma, keying off clinical research and education and sustainability. That's across all skin disease. But of course, what happened in Myanmar 2 years ago was that they had a military coup. And of course, when that happens, it became a very dangerous environment for the healthcare workers. But it's the most dangerous place in the world, still, even with the Ukrainian war, to be a healthcare worker. And therefore, our dermatology colleagues in the country went into hiding. Some of them had to leave the country. Medical students and young doctors started to come to the fore to try and take on some of the management of not just skin disease, but healthcare in general. Still a dangerous place to operate. But what do you do when that happens? Do you say, well, we can't help you, we can't go back into the country? Or do you think about how to do things differently? And there's something called task sharing. So dermatologists can't do it, doctors can't do it, but community health workers can do it given the right sort of training. So what we set up was this, what we call essential emergency skin care. So we developed clinical protocols for community workers to diagnose and manage the commonest diseases, because most diseases we see are not rare stuff. It's the sort of things we see in our own clinics. We had webinars, video workshops, and we introduced teledermatology to allow the diagnosis to be made, so psoriasis diagnosis can be made as well. This is an example of the clinical protocols. Dr. Jing Zhu and Dr. Sarah Walsh were the two who led on that. This is what we did for erythroderma. And interestingly, the reason we have the Ukrainian flag there is the first place to use these protocols was actually in Ukraine, because Professor Tony Redmond, who runs UK Med, phoned me up in April 2022 and said, we're in Ukraine and we're seeing lots of people with skin disease. Can you help? So we sent them those protocols. So they're being used in Ukraine as well, but again, managing psoriasis. And then just to close, we were going to go into Myanmar in a year or so ago, but of course the coup couldn't do that. So working with the IPC, very generous of their time and support, we're able to run a series of masterclasses, which I think a lot of you have been involved in these masterclasses across the world. 5 masterclasses, 2 hours at a time over 5 weeks in November and December. The key points of distinction about this was that it wasn't just in Myanmar. We were able to bring in dermatologists, the very few that there were, from Laos, Cambodia, and Nepal. And, going back to what I was saying, also, for the first time, allowing GPs and general physicians to also be involved in these master classes, so training them in the management of psoriasis. So, in summary, I talked about a lot of things here. GPA is addressing those key questions posed by the WHO. It's a global team. It's expanding. We've got emails coming in all the time now from various countries, want to do more work with us. Epidemiology, we're making progress on that. We're really focusing on making early diagnosis with that diagnostic tool, looking at the availability of medicines, and it's highly variable, as you saw from some of the work in South America. And then as task sharing, I think it's an important concept as to how we can manage more people with psoriasis around the world, and not just those in the privileged countries in Western Europe and elsewhere. Thank you.
Thank you. Thank you, Professor Griffiths. You're really shaking our floor with your lecture.
I was just thinking, I'm glad that you were feeling that as well. I just thought it's because I had a late night, but there you go.
So, please, the first question.
Thank you. Lars, I'm a patient research partner from Denmark. Thank you very much for all the work you do on the GPA. I guess my question is, for Denmark right now, the prevalence is rated to 1.91%. Recently, Professor Ebjerg, who's part of the consortium, did a new prevalence study that says that it's at least 2.2%. So I guess my question is, how and when do you update the GPA, which is very important? The reason I'm asking is, of course, that the 60 million is an important figure. Yeah. It's been used by a politician. It's been used in our work. So it's hugely important that the figure is as accurate as possible. Yeah. Allow me just a little reflection when it comes to Greenland. Coming from Denmark, we know a little about that. And as you mentioned, we didn't think there was any psoriasis in Greenland. It now turns out there is. So that adds to the number, I guess.
Yeah.
And I would find that in other parts of the world, you will also see that the diagnosis of psoriasis is not accurate. Finally, on the GPP, you also mentioned that is not included in the number. It's not a huge number, but it will add. Yeah. So it's really important that you look very detailed into that number. It might not be 125, but it's certainly more than 60. It might be more than 125. So I just question, and allow me to do that, question if you really have all of the psoriatic diseases included in the GPA. Thank you.
Sure. You make two very good, several good points. One about the 60 million. We can say with certainty it's at least 60 million. It's going to be higher than that, but we'd like to be accurate. That's the whole point of doing the atlas. The prevalence is probably going up in countries around the world. It's going up in the UK. And that's not because the incidence is going up. It's because people with psoriasis, like the rest of the population, are living a bit longer. So, you know, there's that population of the older population with psoriasis. They're still living shorter lives, but they're now living longer than they did a few years ago. But you make good points about the GPP as well. Yeah.
Sir, I'm Dr. Singh from India. My question is general question on therapeutic of psoriasis. Beta blockers is known to trigger psoriasis because it increases because of its act on cyclic AMP and adenyl cyclase. And psoriasis is also associated with asthma. Is there any role of beta adrenergic agonists in the treatment of psoriasis, sir?
Well, you know, the question is about beta blockers exacerbating psoriasis. I think that's actually quite rare. It's in all the books, but I don't think many people see that nowadays, if at all. I mean, I've seen it. I've seen it once or twice.
I've seen it. My sister is a cardiologist.
I was just going to make that point. So you're already sensitized to that.
She rang me up and said, have you ever heard of beta blockers causing psoriasis? She's telling me. Because she found out that two of her patients, actually they were children, interestingly enough. She stopped the beta blocker, the psoriasis went away.
Yeah, so there's a definite link. For sure, it occurs, but I don't think it's as common as it's made out in the books. But yeah,
Yes.
And then using beta agonists as an interesting idea. I'm not aware of that. Yeah.
Yes, sir. In fact, I was trying to do with salmeterol as topical therapy, sir, but I don't know whether it will be useful or not for the treatment.
Well, I don't know. We can maybe talk about that. Yeah.
Yes, Thank you, sir.
Thank you, Chris, very much. Great lecture.